Hello, everyone. We are going to study the surgery chapter 37 knot and diseases of rectum and anal canal section 7 carcinoma of the rectum today. Carcinoma of the rectum is one of the common malignant tumor in China, and its incidence rate is not second to gastric carcinoma. Among colorectal carcinomas, the incidence of carcinoma of the rectum accounts for 60% to 70%. Carcinoma of the rectum is a cancer from the dentate line to the junction of the rectum and the sigmoid colon and bounded by the peritoneal reflection. According to its distance to the brim of the anus, it is divided into high, mid and low carcinomas, with the distance to the anal brim respectively being over 10 cm, 5 to 10 cm and within 5 cm. According to the statistics of the epidemiology, the incidence rate of low carcinoma of the rectum is higher, accounting for 60 to 70% of all carcinomas of the rectum. Because of its low position, the digital rectal examination DRE and the sigmoidoscope are the common examination methods. Mid-carcinoma of the rectum is close to the sphincter of the anal canal, and during operations, retaining the anus and its functions is a tough task. The histological classification and the clinical and pathological staging of carcinoma of the rectum are the same as carcinoma of the colon, and therefore will not be elaborated in this session. Next, we are going to talk about the spreading and metastasis of carcinomas of the rectum. The first metastasis route is direct invasion. A rectal tumor invades along the intestinal wall to deeper places, for example to men's prostate and seminal vesicle, or to women's uterus, vagina, etc. It may also invade our bladder. We should note that it takes a rectal tumor 1.5 to 2 years to invade the full length of the intestinal wall. The second metastasis route is the lymphatic metastasis. According to different positions of carcinomas, there may be some slight differences in their metastasis routes. They often metastasize to lymph nodes on the colon of the diseased intestines at the beginning, then in turn to lymph nodes aside the intestines, intermediate lymph nodes and lymph nodes at the root of the mesentery, and at the advanced stage, to supraclavicular lymph nodes far away. It should be noted that the metastasis to lymph nodes is not necessarily continuously, and may be saltatory. Therefore, the high ligation of the mesenteric artery and cleaning lymph nodes at the corresponding positions during the operation can reduce the post-operation recurrence. The third metastasis route is the hematogenous metastasis. Tumors metastasize to distant positions through blood circulation, and according to the positions of tumors, there might be a probability of a distant metastasis tendency and might be different positions. For example, a carcinoma in the mid or upper part of the rectum may be metastasis from the liver, while a carcinoma in the lower part of the rectum or in the anal canal may be metastasis from the lung. The fourth metastasis route is the plantation metastasis, generally from the breakthrough of a high carcinoma to our serosa or to the exterior of our tunica externa. With the above knowledge in mind, we should also have some knowledge on the clinical manifestations of carcinoma of the rectum. There are no apparent symptoms in the early stage of carcinomas of the rectum, and this is the reason why the diagnosis of malignant tumors is difficult in the early stage. Symptoms only occur when a carcinoma begins to affect the defecation or to ulceration and bleeding. It is a reminder that the DRE is necessary for examining patients with diseases of the rectum and the anal canal. Constant urgency of defecation, change of defecation habits, feeling of anal pendant expansion before defecation, tenesmus, feeling incomplete defecation and a hypogastralgia in the advanced stage are symptoms that the rectum is irritated by the tumor. After ulceration of the carcinoma, the symptom of hemorrhage of the lower digestive tract may come up, such as blood and mucus on the feces surface, and even bloody stools. With the invasive growth of the carcinoma, the entire intestinal wall is attacked, resulting in a narrower bowel lumen. At the early stage, feces becomes thinner and thinner, and the typical manifestation is the feces is as thin as a pencil. When the intestinal canal is partially obstructed, symptoms of the incomplete ileus such as abdominal pain, abdominal distension, hyperactive bowel sounds, etc. occur. At the mid and the advanced stages, the carcinoma invades surrounding tissues or metastasizes to distant organs, leading to the corresponding symptoms. For example, when the prostate or the bladder is invaded, symptoms like frequent urination, urgent urination, dysuria and hematuresis may occur. If the vagina is invaded, abnormal secretion may occur in the vagina. If the presacral nerve is invaded, an acute and persistent pain may occur at the tail. In terms of local symptoms, hemiphagia is the most common one, accounting for as high as 80 to 90%, followed by frequent urination, stringy stool, mucus in stool, constipation, tenesmus, etc. When examining a patient of carcinoma of the rectum, we should be familiar with the corresponding positive signs. 1. DRE, 60 to 70% of the tumors can be reached in the DRE. The DRE therefore is the most important means to diagnose low carcinomas of the rectum, and any rectal irritation symptoms, hemiphagia, stringy stool, etc. shall be adopted. After the DRE, the position, size, hardness, shape, distance from the anus, of the tumor, as well as the bloodstain condition on the finger stall shall be recorded. If it is on the antitheca, the relations of the tumor with the prostate shall be noted. If the patient is a man, and if the patient is a woman, its relations with the vagina shall be noted, and if necessary, the vaginal touch shall be carried out for confirmation. 2. Due to different characteristics of lymphatic drainages superior and inferior the dentate line, the inguinal lymphadenectosis, in most cases, relates to carcinomas of the rectum inferior the dentate line, and the chance of a squamous carcinoma is high. 3. The complications of advanced carcinomas of the rectum include ileus symptoms after the bowel lumen is blocked completely, such as paroxysmal abdominal pain and hyperactive bowel sounds. If the metastasis has reached the liver, cachexia such as hepatomegaly, jaundice, ceroperitoneum, etc. may occur in the end. Auxiliary examinations for carcinomas of the rectum mainly includes lab tests, the endoscopy and the imageological diagnosis. In lab tests, the stool OB test may be used as a primary screening means, then positive patients shall be further examined, but negative patients cannot be completely exempted. The carcinoembryonic antigen of tumor marker and the CA19 and 9 is not significant in the clinical diagnosis, and are mainly used to monitor and evaluate the postoperative reoccurrence and the prognosis of carcinomas of the rectum. Endoscopes include the rectoscopy, the sigmoidoscopy and the colonoscopy. A sigmoidoscope is able to examine all of the rectum and part of the sigmoid colon within 25 cm from the brim of the anus, and all you need is to clean the lower large intestine. Through the examination, over 60% or 70% carcinomas of the large intestine can be discovered. For colon carcinomas over 25 cm from the brim of the anus, the colonoscopy is the most reliable means of examination. However, bowel preparations shall be made, Pathological changes can be directly observed in the examination, and in the meantime, and living tissues shall be extracted for the pathological diagnosis. This is also the basis for drawing up a treatment program. The imageological diagnosis of carcinomas of the colon and the rectum have their respective advantages and disadvantages. Through the conventional abdominal B ultrasonography, the detection rate and the diagnostic rate of rectal carcinomas are both low, but the diagnostic rate of substantial metastatic carcinomas in visceral organs is high, and the swollen lymphatic metastasis in the enterocolea can be displayed. Through displaying the invasion of carcinomas of the colon and the rectum on neighboring tissues, the CT-enhanced scan provides a more accurate judgment for the clinical diagnosis. In clinical practices, effective and accurate examination methods shall be selected as the actual circumstances may require to improve the preoperative diagnosis rate of the carcinomas and to develop a suitable treatment program to effect a radical cure. In the end, we are going to study the treatment of carcinoma of the rectum through operation, chemotherapy, radiotherapy, Chinese medicines and psychological adjustment to relieve the pain and improve the life quality of patients. We should know that the surgical treatment is the preferred therapy method at present. Different therapies shall be chosen according to the pathological staging of patients. 1. A radical operation is to excise a tumor and clear lymph nodes in a certain area. 2. A palliative surgery is, when the local invasion of a carcinoma has become serious or the metastasis is too extensive for a radical cure, to make a palliative excision to reduce the obstruction and relieve the pain of patients. According to clinicopathological studies, the invasion range of rectal carcinomas to the distant intestinal wall, that is towards the brim of the anus, is smaller than that of colon carcinomas, and only 2% rectal carcinomas invades more than 2 cm. This is an important basis for the selection of operation methods. 1. The local excision is used for rectal carcinomas below T1, for which, at least a 3 cm incisal margin shall be ensured. 2. The radical excision is to completely excise the carcinoma and enough margins, regional lymph nodes, concomitant vessels and the complete mesorectum. The main surgical techniques include the Miles's resection, the Dixon technique and its derivative techniques, and the Hartmann technique. While applying a radical resection of a rectal carcinoma, adequate considerations shall be given to the life quality of the patient, and the urination and sexual functions shall be protected during the operation to the greatest extent. At present, the radical resection of a rectal carcinoma with the peritonioscope is usually adopted for its advantages in a small trauma, fast recovery, etc. The effect of the operation is definite. 1. Abdominoperineal resection, Miles resection, resection of the entire mass and clearing of lymph nodes are carried out simultaneously via 2 routes, the abdomen and the perineum. Part of the levator in the perineum, the adipose body of ischianal fossa, 3 to 5 cm skins around the anal canal and the anus, subcutaneous tissues and the entire anal sphincter shall be excised, and a permanent single lumen colostomy shall be made for the sigmoid colon in the left lower quadrant. 2. Low anterior resection, La Dixon resection. This is a sphincter-preserving operation and the most commonly applied radical resection of rectal carcinomas. After tumor resection, the primary anastomosis and connection of the intestinal canal shall be carried out. And the principle is such: the excision margin shall be at least 2 cm for distant ends and at least 1 cm for low carcinomas of the rectum. As long as the external sphincter muscle of the anus and the musculus levator are not affected, this resection can be carried out, provided the peripheral excision margin is negative. 3. Abdominoperineal resection, near-end colostomy, and far-end closure. Hartmann's procedure: after tumor resection, carry out the near-end colostomy and the far-end closure procedure. The time of operation is shortened as operations in the anus are avoided, and this method is applicable to patients who are poor in general conditions, who are unable to withstand the Miles resection, or who are subject to acute obstruction to which the Dixon resection is not suitable. 3. Palliative excision. The palliative excision for advanced rectal carcinomas is intended to relieve the pain and treat the complications. For example, dual lumen colostomy of sigmoid colon is intended to relieve the intestinal obstruction and the difficult defecation. 2. Radiotherapy is to kill the cells in the exposure field through focusing radioactive rays, and is a local treatment. The perioperative radiotherapy can improve the chance of healing. 1. Preoperative radiotherapy. A large scale of random clinical tests indicate that auxiliary preoperative radiotherapy can reduce the tumor, decrease the stage, improve the resectability, and reduce the local reoccurrence. 2. Postoperative radiotherapy. The effect is not as good as the preoperative radiotherapy. 3. Palliative radiotherapy. For patients of the advanced stage or subject to reoccurrence who are impossible to cure, this radiotherapy may relieve local symptoms. 3. By utilizing the high sensitivity of tumor cells to chemical medicines, the chemotherapy selectively kill the cancer cells. The administration routes include the systemic intravenous administration, postoperative hypothermic intraperitoneal chemotherapy, etc. The systemic chemotherapy after the radical resection can improve the 5-year survival rate of rectal and colon carcinomas of stages 2 and 3, and the common medicines for auxiliary chemotherapy include fluorouracil, oxaliplatin, calcium folinate, etc. That is all for this section. Thank you.